Hey everyone, this is the Nips and Sips podcast show featuring me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about, does the pop really matter when we talk about joint manipulations? Does the cavitation really make a difference or not? There's some research saying that it doesn't. By as experienced clinicians, we're going to put our insight to it. Before we get into it, Brandon, how's it going?
Oh well, man. Looking forward to this conversation. We have talked about this in the past. Side conversation. We had a course a couple weeks ago where it was brought up there in conversation. I know you're doing some mentoring now with a former fellow. Came up in there. A lot of layers to this, and I don't think there's one steadfast opinion on it, and there used to be, and we'll share our experiences on what we used to think, and now that we're older and wiser, what we now think.
Yeah,
Jeremy, you're catching up. You just had a birthday.
Huh?
I said you're catching up in age. You just had a birthday.
I know. So I'm trying to catch up, my man.
You can't keep saying I'm the old man.
Yeah, no. I think I have more gray hairs than you do.
Right.
So,
I'm thinning now. I'm thinning.
Yeah, that I still got, But every once in a while I sleep funny. I'm like this. I'm like, oh shit, today's the day. But I'm all right for now. So but the gray hairs are coming in plentiful of late. So, but yeah. But first things first. What's on the docket for drinks?
Got the big boy here. Some Clase azul given by none other than himself, Mike De La Cruz,
legend,
my primo, and I'm drinking it in a lovely Pursuit PT glass there,
nice.
Low ball glass. So that's what we got. What do you got going on?
Oh, I'm mixing it up on you. First time in show history. I'm going for some booze.
Ooh.
Yeah. So this is
a monumental moment here.
Huh?
It's a monumental moment.
I know. I don't know. This might be this is the 75th episode. So maybe that's the reason why. But I got some bottles recently and then started looking at my bar cart over there. And if I don't start putting more work in, it's going to start really getting out of hand. But my main man TJ hooked me up with this for my 33rd. We had a little sipsies with it. It was delicious. So I'm still gonna pour it out. Not that it's gonna make that nice fizzing noise, but it was a beautiful bottle. It was delicious. I am drinking it out of a awesome glass that my honors bio teacher, who became an amazing close friend to me, helped me get into PT school. Our son's a dear friend of mine, Drew. This is for Dr. Murphy. She got me this glass, which is the longitude, latitude of where I got married in Philadelphia.
Oh, nice. That's awesome.
And she got me another glasses. I think the wine glasses were the longitude, latitude of the first trifecta location. So it was pretty cool.
Oh, that's dope. That's dope.
Really dope gift. So a little toursy there, and got some actual rocks in there. I forgot how I got those, but
yeah, I got frozen bullets in mine.
That's pretty cool. So cheers.
Cheers, man.
It'll be interesting to see how it affects me throughout the rest of the day. Usually the beer, sometimes I'm not too bad. Other times I'm pretty sluggish, but I haven't really had much middle of the day Scotch whiskey. So
better than the days when we used to try and plow out 2, 3, 4 episodes, and by the end we're spacing out and slurring our words. And
those were the days. And we get people who keep like mentioning like, oh, I went back and heard some of your older episodes. They mentioned the EDM song that was regrettable. And that they're like, yeah, I can tell when you're a couple episodes deep. I'm like, those were the days. Doing episodes in cars and stuff like that.
Hey, that's part of the evolution, man. We started, we're in our 20s when we started that. I might have just turned 30, I think.
We're just about to hit our 4-year anniversary of the show, I think.
Yeah, we've had obviously some times where we weren't as consistent. Obviously, life gets in the way, marriages, opening up offices, fellowships, whatever, you name it. We were trying it out. We used to do this for our audience. We used to do this on our cell phones off this app called Anchor, which
Oof.
at the time we thought it was good. It was a recommendation by Gary V. So I guess it was good, but not really.
Yeah.
Get interrupted by phone calls and text messages,
Oh,
or we'd lose service and we'd have to stop. It was always blotched out.
yeah.
But that's all right, man. We didn't start off perfect. We're still not perfect. We're getting there. It's been, like you said, 4 years, going on 4 years. I mean,
4 years coming up. Yep.
like, who would have thought?
Yeah.
Things are now, things are starting to take off. We're having more listens. We're having, people coming in and mentioning stuff, and
Mhm.
signing up for courses because of it, or internships because of it.
Yeah.
Had somebody reach out from what state was it? Minnesota, to do an internship here all the way in New Jersey.
Wow.
Things fell through with the contract, so it didn't happen. But awesome that you know they reached out. So
That's pretty
we're
cool.
making a change somewhere, hopefully.
Yeah, 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 yeah. Awesome, awesome. Um, Start from the bottom, now we're here, right? And we're
Yeah.
still going up, but just like our clinical careers as well, same process. We look back and kind of growing about how we once were, and how much we've grown since, and we still got a lot of growing to do. But speaking of today's topics, let's talk about pop and wait. Oh yeah. Hopefully
I
that
don't, I
hopefully
don't know
that
how you
got
do
through.
that.
Huh?
No, I can't. My fingers don't do that.
Yeah, yeah.
I'm all cracked out.
Oh,
Yeah.
there you go. Let me should I get the neck one? Should we do that? Hold on. Oh, there it is.
All right. For anybody listening to this via audio, go on YouTube and watch this, and watch what Jeremy just did. Because he'll do this like in the middle of like courses, and we just be like in the corner, just like spinning his neck. I'm like, dude, what are you doing? You look like you're going through something where you're tweaking out, going through withdrawals.
Where I was just like kept doing it. I was like, I couldn't get it. And that's a perfect example where I wanted a pop and I just couldn't do it, and didn't think about what it was probably looking like as you're presenting the course, and I'm in the back going,
Looking like a dog with a cone on its head, trying to,
okay, man, what the hell's
scratch.
wrong?
But yeah, on to the pop. I mean, we like the pop. We're self manipulators. We obviously like manual therapy. We like manipulation. We like the cavitation. I am sorry to say, cite all the research you want. If you manipulate somebody and you say you don't care about the crack, you're lying. You just are. We all want the crack, right? Is there research saying that it's not the most important thing? At least research wise, or physiologic wise, things like that. There's research that says it is important. We're going to loop in how what the patient's perspective is, how that ties into evidence-based practice. But yeah, I think, if you're a skilled clinician, if you're, practicing your craft, in the beginning, you may not get them all the time, but if you're doing it for a period of time, you should be getting those cracks, especially on, your T-spine manips, a cervical upslope, a side lying lumbopelvic. Yeah, there's certain techniques where you don't get a cavitation. It's not designed to get a cavitation. We're not talking about that. And Jeremy, I don't want to take away his thunder, but there's thoughts out there that you don't need the crack, so it's okay. And I'll pass it off to Jeremy so he can talk about that.
Yeah. This came up from doing a fellowship round, or mentorship round per se. And I've heard it before from resident students, even myself at times. I used to probably say this verbatim. I'm going to do a technique to you, a quick stretch. You may get some pops or cracks out of it, but it doesn't really matter if you do or you don't, according to research. So boom, a couple variations there, if you will. So I heard it and that sort of stuff, and then we had a conversation about it. The fellow in training I'm working with works more in neuro, Phil, amazing PT, but he's not as much into outpatient orthopedics. So we're working on the manipulations and stuff. So when I have more experience, I can do that sort of stuff a little bit more easily. And the in that particular case with the patient, once I came in and did it, maybe it's the ritual of Jeremy, I'm the owner, I'm the one doing some of the mentoring, and it had more of a placebo effect. Or was it, when I was able to elicit the pop? I think we set up ourselves for failure when we kind of start off with that conversation, where we're almost setting us up for not getting a pop, and setting up as the expectation. And okay, well, it's good enough if me just doing it. And I can remember so many techniques that I put up that cuboid whip, progression over my lifespan, I guess. And it's so much more crisper. I get so many more cavitations now. But if I settled on how I did things 8 years ago, 9 years ago, I would still be getting the same results. And I can say, when we do get those cavitations, I believe there is more of a grand effect. You get the more that you just don't get when you do upslope and you're like, that didn't go. And they're like, yeah, it feels a little bit better, which what we always say is probably not much better at all.
Yeah.
But that, I think that's we're taking some of these research studies that previously said the pop doesn't matter, it's maybe the speed or how you apply the technique that's really important. And we're taking them to heart and apply that to everything. Oh, if it doesn't work, if it doesn't, okay, that's good enough. I really don't think that's the case. As someone who practiced like that, and just anecdotally over the years, seeing the individuals that was able to elicit a cavitation, it seems like it had a more grander effect. And to the point where I wouldn't need to do more manipulations afterwards. Like there was some times where we finally got things to go, and then the next session they come back, they're feeling so much better. I'm like, oh, we can do it again, whatever it may be. They're like, I'm good, whatever it may be. So that's my experience with that. I hope, especially students and that sort of stuff, they just get these techniques. Maybe they get, I remember when I went to go teach manipulations at class, it was like an hour for 30, 40 kids. Boom, 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 boom. It was impossible to get to everybody. And you're learning these techniques, you want to apply them, and you just may not have the speed, the confidence to do them. And we just settle there and we take that research and say, hey, that's good enough, but it's probably not, in my opinion.
Yeah. I was, similar, with my evolution, but I think you said something important. Does that lead to the notion the cavitation doesn't matter, so people don't bother to spend the time to hone in on their skill set? It's like the saying, oh, we're not as specific as we once thought, so specificity doesn't matter. I mean, yeah, but no. Same thing with the cavitation. Yeah, but no. Like, you look at certain research, and who was it? The Flynn and Childs article talked about, does the pop matter? And they said, no, it doesn't. And yes, from a muscle spindle stretch reflex aspect, we're looking at the speed of the technique. And you look at Reed's article in 14 and 13 that we talk about in our spinal manipulation course. Yeah, that the premanip hold and mini thrust will increase the speed at which you're able to do it, and therefore the neurophysiological effect from the muscle spindle, right? And the afferent fibers, gamma and C fibers and all that other stuff, right? That gets stimulated faster with speed. But what about the other side, which we've also talked about, on that it kind of gets encompassed or encapsulated in the neurophysiological effect, is those chemical effects. Well, that cavitation we know is a drop in pressure within the joint space from a separation, quote unquote, of the joints being separated. So that's going to create or induce a chemical effect. That chemical effect is going to have carryover into the spinal cord and brain, which is going to mediate a lot of different things, especially in terms of pain. Also in improving range of motion. Now we go into patients' expectations. Evidence-based practice, a pillar of evidence-based practice is patient expectations. So if they're expecting a cavitation and they don't get one, did we fully meet all pillars of evidence-based practice? which goes to our other podcast where we talk about evidence-based practice, is not just the research. It's not just the so this is where our evolution now, after 8-9 years teaching the stuff, residencies, fellowship. I mean, we sleep, eat, and breathe PT more than probably 99% of PTs. We get to have these conversations, and these conversations help our evolution. They help our thought process. We then, get to look at different research and apply this article and that article, and and now we get a more robust framework and reasoning and decision making for it. And it's funny because sometimes we like to be validated, right? And you and I kind of felt this way probably for a while. And I remember coming back after a weekend a couple years ago, fellowship weekend with Josh Cleland, the man, the myth, the legend, right? Probably one of the most renowned physical therapists and researchers on the cervical spine. Luckily, I had him as a CT during our CT course, and he said something where it's like, yes, I knew it. Like, I felt validated, whether I needed that or not. But when it comes from a superior, somebody who puts out 300 articles on this topic, it's like, great. And he's like, yeah, in the beginning, you're probably not going to get a lot, but to master this technique or to be proficient, you should be getting, cavitations pretty regularly. May not happen all the time. Don't get me wrong. There's some patients who just don't cavitate, or maybe they're really tight, spasming, et cetera. But for the most part, if you're proficient, you should be getting some cavitations on most of these techniques. And when you look at it from the patient's point of view, whether it's erroneous or not, there's research saying beliefs in population about cavitation sounds, and we need to do our job and educate our patient. But that doesn't mean we're going to be able to de-educate every single patient and re-educate them, right? They're going to have their beliefs, and that's okay. And if their expectation is a cavitation and you didn't meet that, well, is it going to help with buy-in? Did you meet their needs? And like Jeremy said in the beginning, when we crack our own necks, or he cracks me or manipulates me, or I probably shouldn't say cracking, but as a scientific term, but we're looking for that cavitation. I think that's it's only natural. So
yeah, I think you brought up some great points there, especially with the education side of things. I think a lot of where this comes from is like the whole, also tied into the adjustment thought process, and if you get cracks and pops, and it fuels that idea of we're just fueling that concept and people need to be realigned. No, it doesn't have to be that way at all. Every time I do it, I'm like, do you know what happens when we have the pops? And most people don't know. And some people will say the old school thought process of, that's some bones getting back together. I'm like, no, it's not quite how it works. You're not like Humpty Dumpty and maybe put back together, but we're just moving the joint at a certain speed, and there's some air bubbles, if you want to know the specifics: nitrogen, oxygen, hydrogen. I don't do that too much. And when we do that, when we move the joint and we get that effect, it can have a effect on pain, other things, mobility, and go for whatever they need, or even some activation of muscles or decrease, especially when we're doing some things when we talk about some regional stuff of, all right, this person doesn't have any pain, but maybe they have some difficulty firing up their glutes or their trap muscles and that sort of stuff. And I'm like, oh, I'd like to do this technique. Again, it would be a quick stretch, get some pops, and it may activate some muscles. So you can reframe people's thought process every time you do manual therapy. Some people are going to have their old school ways. And again, Brandon said it, you're not going to be able to de-educate everybody, but if they have enough trust in you and you do good enough technique, they'll start to believe you. I always say that's everybody's opportunity to change them for their lifespan. So if that's what they believe,
value. Sorry to cut you off. Every person is a chance for you to show your value as a clinician, as a profession, as the profession. That's something I look at as, people come in, oh, well, what are you going to do differently? I've been a PT, 6 other times.
Mhm.
I'm fighting uphill. I'm here not only to show my worth and that I'm better, but this profession is or can be better.
Mhm.
Sorry to cut you off.
No, I love that. That's huge. Like that's, I think we go to battle and we're wearing the fatigues of physical therapy. We had a awesome conversation with Kyle when he was up here for the course, and um, obviously Brandon and I's practices are heavy direct access and everything like that. So our mentality first is PT first.
We can fix everything.
Yes, in all honesty, and I'm in the sports, and Brandon, you're also in the ortho realm, and we work with physicians, we work with athletic trainers, and we're not trying to like, oh, it's us versus the world. No, it's not that, but I do think we are in the best opportunity to
It's
treat
better.
the muscular, yeah, in a sense, but because that's how our profession was created in a sense, or that's how it's molded now for certain couple of us, or hopefully more than a couple of us, where we have the ability, the time to educate, we have the ability to perform hands-on techniques for pain modulation and potentially performance-based. We have the time to exercise people so they have the belief of now that they can do more, and that window of opportunity we create, their capacity increases, so there's a psychological benefit of that. They're like, oh wait, I couldn't do that, now I can, and that helps. We have all these these beautiful things, so I obviously want to push that. I know Brandon, you want to do that, and Kyle does as well. But it requires PTs doing these things, getting the job done so people can become proponents of physical therapy. There's too many people out there who've tried it, don't want to do it anymore. Maybe it's because we need to do a better job of actually fixing people, modulating their pain and getting them back to full function. But that's a tangent that went off on
Yeah,
there. I was like, all right, wait, this sounds like this is gonna be a totally different episode. Yeah, I guess a good question there, Brandon. Let's say you have someone, maybe you're a younger clinician, or you have someone that says, I just feel like I just need to pop this. And you tried, and how many times are you trying before you give up on the idea? Or what do you do if you can't?
For the patient or for the
As a clinician
or student?
Assuming these are clinicians listening in. If we have any patients or clients, this would be great.
No, I meant your question. If I have an intern or a resident or a younger clinician not able to get a pop, what are we doing?
Yeah, or how many times would you say you would go before you just give up on it, or that sort of sense? As a young person, if I'm a young clinician or whatever it may be,
as a
I have
young
a
person,
patient
okay,
that says, oh, I just feel like my neck needs to get cracked or popped. And you go in, you do it, you give them the spiel, and it doesn't crack or pop. Do you just stop there? Do you try another
yeah.
round?
So
What do you do?
I think I hear what you're saying. I'm going to give you two different answers just to cover kind of both bases. So anyone knows I'm a clinic, entry level interns, residents, fellows, they're all in pretty much all the time. Like right now, I have SPTs, a therapist out, a year and a half, and a fellow all at the same time. They're all in, right? So well, let's say one of them can't get a manipulation. Usually they call me over. Hey, I think this technique is indicated. Okay, why are we not? We go over some clinical reasoning and make sure we're on par. All right, let me see if I can do it. Usually I can get it. If not, you don't get it. You don't get it. Like I said, sometimes you're not going to be able to get it. Like you, I usually tell my patients if I do ask their permission, which I always don't, sometimes I'm just mobilizing and doing my stuff and it just kind of happens, right? But let's say for whatever reason, I feel the need, I need to educate this person. I say, hey, we're going to do a manipulation. You may hear some cracks or pops. You may or may not hear some cracks or pops. Either way, it's okay. And like you said, if you hear it pops, it's just gas being released from the joint. So now you're kind of covering both bases. You may hear it, you may not. Either way, it doesn't matter, right? I'll go left, I'll go right. I usually manipulate both sides anyway. If I don't get it, maybe I might try adding different vectors, a little more chin, if we're doing a cervical upslope, a little more chin flexion, side glide, maybe hitting a different segment, going a little further down, a little further up, trying to be specific, right? Even though we can't. With that, see if, I change it. If not, chances are they're probably not going to go that day, right? Maybe they need some soft tissue work. Back when I had dry needling and, we're able to dry needle now, countless times you'll get like a neck or a low back that's just the paraspinal, not even a paraspinal, is multifidi is just, it's in spasm. I think we can all agree with that. Hypertonicity maybe is a better word. It's driving, it's compressing down that joint, probably causing a lot of somatic referral pain. I'll needle the area. I remember I had actually a buddy of mine who ended up being a patient, just stiff as it can all be. And it took about 4 needling sessions, hitting his multifidi and his thoracic spine. And then I was able to just have a field day. It was like fireworks on 4th of July, just pop, 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 pop. And then he came in, the next session and we got even more. Like now things are finally opening up. We impacted some changes on the nervous system that maybe took a couple days or a couple weeks to down modulate and, decrease the tonicity and descending inhibition. And that's just understanding neurophysiological aspects and all the aspects involved in what we do and not always looking at the biomechanical side. So I know I gave you probably more than what you're asking for, but that's pretty much what I do. And I think, sometimes it just doesn't go and that's fine. I let it be. I'm not, sitting there wailing away. Here's a funny story, actually. I don't know if you were in residency during this, but you had to hear this story. Cheryl and I were in residency and there was another student there who you could tell it just wasn't her setting. I think she had a couple years. My couple, probably like 5 or 8 in like the inpatient world, was transitioning to outpatient. So she wanted to brush up. So she's a residency. Makes sense, right? So we're on virtual rounds and, she's presenting on a low back and she's like, yeah, I thought the patient deserved a manipulation or required a manipulation or response. So I did it and retested, nothing happened. No cavitation. So I did it again. Nothing happened. So I wasn't sure. So I did it one more time and nothing happened. So now we're at 3. So then she goes to the other side and does it like another 4 times. So like all I remember was that she did like 7 manipulations in like a 5-minute period to the same region. It's like, okay, that's probably not where you're going to get your bread and butter today. That's fine. You don't have to keep doing it. So it was a running joke between Cheryl and I for a while on
I don't think I heard
lack
this
of
one.
clinical reasoning and stuff like that. It's just funny. Obviously, she's there like anybody else to get better. But, that's a case where, you try it once or twice, it doesn't work, go on to something else. Another thing you could do maybe is try treating regionally. If you're treating the low back and it's not going, okay, let me hit the T-spine, let me hit the hips. Let's work on that area. Let's see if we can modulate, make some type of chain there. And then we could go back to the back in a couple of sessions. So maybe I do some neurodynamics, right? Loosen up the, pathways that way. And then hit it. Just try other techniques and then go back.
Yeah. I think most people won't know, especially if you hit regionally, won't know where a lot of the cracks are coming from, especially like T-spine to lumbar spine, maybe upper T-spine to, some cervical thoracic or cervical. But yeah, it's a good example with probably too much, and then potentially installing more fear, like why is this person trying this so many times and, keeps retesting and everything like that. But
I'm going to flip the question. What was your, do you have a different thought process than that for the audience? And then also with that, your conversation with Chris, the guy who you're mentoring, if you could shed a little more, light onto, was there discussions on the research? Was it, hey, I used to think this, but now I think this, what was did he have an aha moment or a light bulb or, what was his response to that conversation? I think that's the big thing about mentoring is you get to pick other people's brains and not necessarily just learn techniques. Like that's like probably like the least thing valuable you get out of a mentorship.
I agree. I think a lot of it's, as you say, is like, you're there maybe mentoring someone, but it's more for me as well. As a mentor, it's like, I want to hear your rationale and thought process to enhance my own. last like 3 mentoring sessions, I've picked up on some great nuggets and some great metaphors and analogies. Mine are getting way too stagnant, way too old. Props to Tara. She made this great waterboarding one, which sounds vicious on the line. I'll go more in depth into it. And then Chris had a great FEMA one, like earthquakes and all this sort of stuff. But it's always great to just get other people's insights and that sort of stuff. Me personally, I totally agree. Try different areas. And just don't give up on it. If it's something you feel like it's beneficial, maybe they're benefiting from mobilizations, or maybe the manipulation and didn't cavitate, doesn't mean you give up on it and that sort of stuff. I can't tell you how many people I've had where it's like the second, third, or fourth session. That's when they finally go, as you say, like fireworks. But if you gave up after that first one, because it's like, oh, it didn't work, and it doesn't really help out the confidence when you're there and you're like, and it's like, oh, silent. But you keep going at it. Again, there may be some things, some guarding of the nervous system and all this sort of stuff that's not allowing you to get to the range to cavitate, or the speed, or the patient, again, maybe holding back on you a little bit, and therefore is restricting your speed in order to get to those cavitations. So that's my thought process with that. In regards to Chris, and when we were talking about it, he's fully kind of on board with it, and we were going over into the studies and everything like that, and I brought up more of my experience, because I have obviously more experience with manipulations. He's more in neuro, but he's had some people where it's tough for him. He's working with spinal cord injuries and people can't get in positions, so he'll do what he can and that sort of stuff, but or he'll like shy obviously from cervical techniques, but yeah, he's talking about it, and he's saying the same like thing, like I don't know why we kind of bring that up in a sense. Especially I think he was acknowledging the fact that his lack of experience doing it kind of fueled that piece there. When I looked at it and I was explaining myself, was I'd say the same things verbatim when I was younger, and then just naturally over time I just kind of stopped saying it so much. And so I think it's good to have that self-reflection in a sense. And then I was like, the more and more skilled you get at it, the less and less you're going to have to say that. But definitely in his setting, I'm excited. I'll be actually going to his inpatient rehab, or his neuro intensive rehab, and doing some mentorship there and seeing that. And,
let me know if you guys try some neurodynamics on some of these stroke and spinal cord injury patients. I would like to see if it's, one, being done, and two, how effective it is.
Oh, it is. We've had some, that's probably where most of our conversations actually have gone to.
Nice.
We brought up some things, and then he has someone where I may be wrong, Chris, if you listen in on this, sorry that I screwed up the numbers. But it's someone, I can't remember what level, spinal cord injury. So sorry, I'm getting old, but had some issues, walking, pain, everything like that. Couldn't do like a straight leg raise more than, I think you said 20-30 degrees. This is where I'm going to get messed up. But within, I think, 2 sessions, him doing neural dynamics, he was getting the guy up to 70 degrees and making an improvement.
That's awesome.
So went from 45, I want to say it was like 20, 30. I'm losing numbers this year.
Let's say it was 30, and let's say you got to 60. It's still a 30-degree improvement.
Yeah.
I mean, that's still significant
in the neuro realm. So like he's mentioning, like, again, he does some things that nobody else does. And again, we put these hats on, and I applaud, Chris to the 9th degree here. Is like, he's gone and continues to improve himself and bring things, different elements in. Chris has been on our show. You guys go back, look up Chris Carroll. It was an amazing episode. He was on our PT Reframed. He's the type of person, you listen to him and you want to get into neuro yourself. But yeah, he integrates this sort of stuff. And that's part of like I talked to him about it. It's like, I brought it in. I was like, is there any real research of like us not doing manipulations on, post-stroke individuals and that sort of stuff? Like, there really isn't any. He'll do T-spine stuff. So we've discussed that. And he's like, especially the chronic ones, like he's seen people that have had their stroke 15-20 years ago.
Yeah, why not?
This is like, why not? We start having these conversations, And me personally, I'd get people who had strokes years ago, and I'm like, nope, can't do that one. Well, in all reality, what's saying that we can't? Yes, they might have had something, and the big fear around, especially like cervical techniques, is you're going to throw a clot or whatever, occlude the arteries to the brain. But really, there's really no evidence to suggest that.
You wanna know what says no? These damn RCTs that exclude these type of patients because they only need a certain type of patients. Like that's my beef with randomized control trials. They exclude too many people that we see everyday life.
Yeah, if you're going to exclude them, you should at least have a separate study having them in it. That way you can say, well, in that study,
Then that's another thing.
Like
then
30
you
studies.
run to ethical dilemmas and IRB reviews and all that other stuff. So obviously you can't do, that's just a limitation in randomized control trials. But if you're out there, and hopefully Chris starts doing some case studies or some write-ups, because this dude's a NCS in a neuro setting doing an orthopedic manual therapy fellowship. Like awesome, amazing.
Awesome.
All right. Okay. Hold on one second. I'm gonna call here. Hold on. Emmett's calling. Yeah, bud. Let me call you in 2 minutes. I'm just finishing up this podcast.
This is how
You
live
should say hi. I want you to yell hi to the audience here.
This guy. There we go.
You guys heard that? Hold on, let me put you on speaker. I gotta put you on speaker for that, Emmett. There you go.
Dr. Rojo himself.
What's up, Magnificent Sips?
There it is.
Was it his birthday? I think
it was his birthday yesterday. Yeah.
Everyone, happy birthday to Dr. Rojo there, the redhead.
It's an honor to get that from you, Dr. Boyd.
Oh wow.
Sometimes give me like 2 minutes. Yep. Bye. Yeah, so we do this live unscripted, as you guys can tell if you haven't noticed already. But with that, I guess we'll sign off for today.
Yeah.
Gotta do some work stuff. Great talk, great podcast. We'll see you guys next time.
All righty. Cheers, everybody.
I'll see you guys.